Hi, everyone. Thanks for joining us from near and far. It's my great pleasure to introduce today's guest, Stepháne Helleringer, Professor of Social Research and Public Policy at NYU Abu Dhabi. Professor Helleringer is a demographer with interests in the development of new methods to measure demographic trends in countries with limited data and measuring the impact of epidemics on population health and mortality. He has conducted several trials of innovative approaches to collecting demographic data, including several employing computer vision and mobile surveys. He has also worked extensively on the impact of HIV/AIDS, polio, and Ebola in several African countries. Professor Helleringer is currently the principal investigator of a multi-country study on adolescent and adult mortality in Malawi, Uganda, Guinea-Bissau, and Bangladesh. He recently initiated a panel study of behavioral change during the COVID-19 pandemic in Malawi. He is a member of the expert group advising the World Health Organization on COVID-19 mortality assessment. Today, Berkeley Demography is delighted to welcome Professor Helleringer to speak about some of his recent work on measurement of excess mortality due to the COVID-19 pandemic. Thank you so much for being here, Professor Helleringer. The floor is yours.
Thank you for the kind introduction and for the opportunity to talk to this audience. It's truly a great pleasure. So I'm going to share my screen. Can do that. Yeah. Can you all see my screen? Okay.
That looks great.
All right, so I'll talk a little bit about ongoing work on the measurement of excess mortality associated with the COVID-19 pandemic in low-income countries, and I'll give you a summary up front so that you know what the message of the talk is and the various steps I'll try to go through. So we start essentially from a fact that most low-income countries, in fact, lack essential data to track the impact of the COVID-19 pandemic on mortality. So we need interim measures or tools to do that. And there are.
I'm sorry. Can I interrupt you? I'm so sorry for 1 second. Is it possible to make your slide full screen actually? Because we're seeing a lot of the sort of wasted space on the side. I think it might make it a bit larger.
Let me see. Full screen mode. That better?
Still looks the same on our end. Anyone else know how to?
No. Let me see. I can try some other way.
Oh, that's much better.
That's better?
Oh, now yep, it's perfect.
Okay, all right. Well, then we'll do that.
Thank you so much.
Okay, so as I was saying, those low-income countries lack the data needed to track the impact on mortality. And there are recommendations and models to try and establish interim system to monitor excess mortality, but in general, they are impractical and or systematically biased. There are also other tools that may be used to track mortality in low-income countries, in particular mobile phone surveys, but we've come across strong beliefs that they can't or shouldn't cover mortality, even though they are routinely conducted now in many low-income countries. So what we try to do with colleagues from several institutions is we try to test the veracity of those beliefs about the feasibility of collecting mortality data by mobile phone into randomized trials that we conducted in Malawi. The conclusion we come to is essentially that we can dispel those beliefs about the fact that those such phone surveys would not be feasible. This is work that kind of extended from ongoing projects about the measurement of adult and old age mortality. with people from several other organizations, including the London School of Hygiene and Tropical Medicine, research institutions in Malawi and Bangladesh, and the University of Massachusetts as well, with support from NICHD, NIA, NIAID, and the Gates Foundation and NYU most recently as well. Okay, so first let me tell you a little bit about the data that we do in fact have for most low-income country, and that's data that's produced by case-based epidemiological surveillance systems, data that we're all familiar with because it's essentially the same type of systems that are available in many high-income countries to track the incidence of COVID cases and the mortality, COVID deaths in most countries of the world. So virtually all countries of the world report periodic counts of COVID cases and deaths. And these are largely based on diagnostic tests for SARS-CoV-2, so the virus that causes COVID-19. These are either PCR tests, antigen tests, and in some instances, these counts also include suspected cases, so cases that meet some clinical definition or epidemiological definition. And we've all been familiar with these, become familiar with these graphs that show how cases accumulate over time since the beginning of the pandemic from various dashboards that are extensively used, like the dashboards from Johns Hopkins, for example. Now, if we look at the data generated by those epidemiological surveillance systems, it does seem like low-income countries have been largely spared by the pandemic, or at least they've experienced a much lesser toll than higher income countries in particular. So if we look at the map generated by those systems, we see a very limited burden, for example, in most African countries and in some other low-income countries in South Asia, for example, whereas most of the burden, most of the recorded cases by these systems appears to be in North America, Europe, and various parts of South America, for example. Now, we know since we've been in this pandemic for 2 years, it is now well known, though, that these data collection systems do miss a significant fraction of cases and deaths. That's true in high-income countries, and that's true in the US, that's true in other European countries, for example, and that's due in large part to the imperfect coverage of testing. And there are many cases and deaths in which the person is not diagnosed with SARS-CoV-2 prior to death or prior to infection. During infection, and in that case, they are not included in those in the data generated by those epidemiological surveillance systems. Now, of course, the proportion of cases on deaths that are missed is likely much larger in low-income countries. So here on the right, you have data on the total number of COVID-19 tests that have been conducted per 1,000 people in various countries. So a bunch of low-income countries like Nepal, Uganda, Ethiopia, and Malawi, for example, and high-income countries like Denmark, United Kingdom, and the US. And I had to put this on a log scale so we could see the testing rates in low-income countries. And you see, for example, that countries like Malawi and Ethiopia have carried out fewer than 100 tests per 1,000 people, whereas a country like Denmark has carried out more than 10,000 tests per 1,000 people. So the likelihood that cases and deaths are in fact detected by such systems and counted in Denmark is larger by orders of magnitude than it is in low-income countries. So now, this is obviously imperfect, and there are better ways to track the impact of the COVID-19 pandemic on mortality. And in particular, one such way is to revert to another type of measure. It's try to measure and track excess mortality during the course of the pandemic. So you all are familiar with that old concept in demography, which can be defined as the difference between the number of deaths that occurred during the pandemic and the number of deaths that would have occurred in the absence of the pandemic. So it's a counterfactual measure and one that captures several dimensions of the impact of the pandemic, of a pandemic, on mortality that are not captured by epidemiological surveillance systems, such as, for example, well, first of all, the deaths that are not diagnosed with a particular disease that are still included in that excess mortality measure. And also deaths that might be due to other causes that might be enhanced by the pandemic because of disruption to various social systems, including healthcare or economic activity, and so on and so forth. And so in a sense, that might be the best indicator, the best measure we could calculate of the total impact of the pandemic on population health and mortality. And here on the right is just one kind of old example of using excess mortality to track the impact of a pandemic on population health, drawn from a parish register that recorded burials during the Black Death in France, in Givry, in 1348. So all this similar type of accounting that is now recommended during the COVID-19 pandemic. Now, what are the data requirements to track excess mortality? Well, they seem simple at first. We need a system that continually records all deaths regardless of cause. So very much like the parish register you saw in the previous slide. And by looking at these, the data generated by such system that record deaths regardless of cause, we can better understand the gap between reported COVID deaths and excess deaths. And this gap includes all the undercounted COVID deaths, so those that may not have been diagnosed, for example, and the deaths from other causes that might be due to indirect effects of the pandemic on other aspects of health and other causes of death. And here's an example from South Africa generated by Rob Dorrington and Tom Moultrie's team since the beginning of the pandemic, where in blue you see the magnitude of the reported COVID deaths, so those that are captured by the epidemiological surveillance system, and the red line on the other hand shows you the excess mortality that is recorded by the all-cause mortality surveillance system. And so the impact seems to be larger by several orders of magnitude, including in some of the most recent waves of the pandemic. So that figure shows the potential use of excess mortality and monitoring all-cause excess mortality as a way to track the impact of the pandemic. Now, of course, the problem we have now is that these data systems that generate information on excess mortality, well, they're largely unavailable for many low-income countries because typically we rely on data from civil registration systems to monitor excess mortality, and in many low-income countries, few deaths are registered. So that's a map that of the coverage of death registration system that the BBC recently produced, where most of the continent of Africa, for example, is classified as having low coverage of death registration. And in practice, what that means is, I'll give you two examples in a study I recently did in Malawi, we found that completeness of death registration was approximately 10%, and 10% of the deaths of the past 3 years were reported as registered to the National Population Bureau. And in Guinea-Bissau, fewer than 2% of the deaths of infants, so a specific age group that's traditionally less registered, were registered in the civil registration system. So it's extremely low levels of completeness in those countries. And what that means, if we look at the global scale, is that essentially we have massive data gaps for most low-income countries. So that's what you can see here from the coverage of the world mortality data set, which is one of the global data sets that has tried to aggregate all the data that are available on excess mortality. And most of the African continent does not have data on excess mortality, as do several countries, several low-income countries and lower middle-income countries in South Asia. So that's an enormous gap in terms of our knowledge of the impact of the pandemic on population health. So to fill that gap, we need interim tools and data sources. And several have been proposed and used during the course of the pandemic. So the first approach to filling this gap really is model-based. So various institutions like IHME, for example, in Seattle, the UN, but also news outlets like The Economist, have extrapolated from correlations between reported and excess deaths observed in high-income countries and middle-income countries, and try to infer what might be the level of excess mortality in those low-income countries on the basis of these expected correlations, assuming for the most part that the correlation between reported and excess deaths would be somewhat the same in low-income countries than it was in higher-income countries, bearing a few adjustments. So here you see that on the map, for example, this seems to imply that the level of excess mortality would be relatively low in most low-income countries, and especially lower than what has been seen in several high-income countries and several middle-income countries as well.
Stephan, could you say another word about what one of those estimates would be based on? I don't understand what data would the estimate for one of these sub-Saharan Africa's countries be based on? A total count of death in the partial registration?
So typically
2020 versus the total count in the partial registration in 2019?
No. So like IHME, for example, would start from the COVID reported deaths and look at how that correlates with excess mortality in high-income countries and in countries where we have both data sources. And then they would start from the COVID reported deaths in low-income countries and assume the same kind of relationship with excess mortality as they've seen elsewhere, and project or predict the level of excess mortality based on that.
But since we know COVID deaths are underreported, how does that address that?
What's that?
How does that address the underreporting of COVID deaths?
It doesn't really. I think in my view it mostly provides numbers and helps fill the map in a sense, I would say.
Okay. So we're kind of just converting centigrade to Fahrenheit or something. We're not changing the thermometer.
Right. Yeah, exactly. And I think that can be debated, but my goal is not to unpack those models more precisely here. Rather, I will mention other recommendations to try and generate actual data about the excess mortality that may be occurring in various places, And the World Health Organization in particular recommends trying to set up some data collection system that can rapidly generate weekly counts of deaths or monthly counts of death at least through the surveillance and the collation of data from health facilities, for example, morgues or burial grounds or cremation grounds in some countries. Typically places where deaths and bodies are managed during the course of an epidemic. And so such systems have been set up or are currently being set up in a number of places, in a number of low-income countries. And sometimes they even use, very, very clever and refined methodologies. Like, for example, here, there are such systems that have been using satellite images of burial grounds and cemeteries, trying to look at how cemeteries have filled up during the course of the pandemic compared to pre-pandemic images, and so on and so forth. So there's really interesting work that's going on in this area, but they have several important issues that limit what we can learn from them about excess mortality. One is that they very often focus on highly selected populations, so namely urban centers or individuals seeking healthcare, for example. There's also possible confounding due to changing behaviors associated with illness and death during epidemics and other crises. So, for example, where people bury their relatives, where people die, might change during the course of an epidemic due to constraints on movement, on mobility, due to cemeteries and burial grounds filling up, due to shortages in manpower in the workforce that's managing burials or cremations, and so on and so forth. So with that, in the end, when we're trying to interpret such data, we don't really know if the changes that we see might be attributed to excess mortality itself or to changing practices and behavior. And there are also very complicated logistics with setting up such systems, including accessing pre-pandemic records, entering them in electronic databases, and so on and so forth. So it's not an easy task to set up such systems. So here we come into our work on mobile phone surveys, trying to see whether they might kind of fill in some of the gaps and difficulties that we have in monitoring excess mortality on an ongoing basis in low-income countries. And the reason for turning to mobile phone surveys is because over time they've become absolutely ubiquitous in many low-income countries. This is already slightly outdated DHS data on the proportion of households that have at least one mobile phone among their members. And you see that in many countries already by 2018 or 19, the proportion of such households was well above 75% in many countries. Most likely has continued to increase since then in some of those countries. So potentially we can reach a high proportion of the population in that way. So that might be a useful tool. And in fact, during starting before the pandemic, and again during the pandemic, there are such surveys, such mobile phone surveys, in which mobile phone users are called by a team of data collectors to conduct an interview, have been conducted with increasing frequencies in low-income countries, and the trend has really accelerated since the beginning of the pandemic, because the pandemic itself meant that in-person survey, the traditional type of surveys, had to be discontinued or paused for some period of time. So the only way to collect data on various topics was really through mobile phones. And they really have major advantages in the context of crisis, because they can be conducted remotely. So no contact between interviewers and respondents, so no opportunities to spread COVID-19 or other diseases. They can be repeated frequently because the logistics are easier. We don't need cars and vehicles to travel to various households. And as we've seen on the previous graph, they can reach an increasing proportion of the population, including in rural, remote areas of a country. So here's the coverage of a World Bank program to conduct mobile phone surveys during the COVID-19 pandemic, and you see that it's already fairly extensive throughout low and middle income countries. So what do we ask typically in mobile phone surveys? So since the beginning of the pandemic, they have covered a very broad range of topics, including economic activity, employment, agricultural activity, healthcare seeking, symptoms related to COVID-19 or other diseases, educational behaviors. So it's really a broad list of topics that have been included, yet hardly any of those mobile surveys have included questions on mortality. One notable exception is one big survey of mortality that has recently been published for India, where it has served to re-estimate the number of COVID-related deaths that have occurred in the country. And there have been also studies like this in Bangladesh on a much smaller scale. So why is that the case? Why don't we ask those questions about mortality in mobile phone surveys? On one hand, there is one central concern that mortality is too sensitive as a topic to ask by mobile phone. We want to ask questions about deaths in the family. Typically, that's what is being asked during such surveys. Deaths among siblings of a respondent, among parents of a respondent, among household members of a respondent. And in household surveys, when we ask those questions in person, interviewers know or are trained about how to mitigate some of the reactions, how to show empathy, and so on and so forth. But in mobile phone surveys, it's unclear how to do this. So there are concerns that mobile users might, on the one hand, refuse to participate at a very high rate, and that the question might cause distress or other negative feelings, and that we would leave the respondents with a detrimental reaction or negative effects on their mental health. So that's one very central concern here. They are also concerned that asking such questions would take too long, and that mobile phone surveys should be kept short, and also that asking mortality questions by mobile phone will generate generally low quality data, because all the probing and the cross-checking of information that's done during surveys that are conducted in person is a lot more difficult to do in mobile phone surveys. Okay, so that's, I mean, I think these are well-founded concerns, but concerns that are generally not necessarily grounded in data. We couldn't really find data to support some of these concerns, and they were largely drawing on experience or a priori beliefs of survey practitioners or people in various positions in ministries of health or populations, for example. So what we set out to do with colleagues I mentioned before is to try and test test various hypotheses about those concerns and try if they materialize when we actually try to collect mortality data by mobile phone. So the first trial we conducted is what we call a within family trial in a small area of northern Malawi that is covered by a demographic and health and demographic surveillance system. So that's a small population that's under intensive study by various teams of data collector that visit every household in that area on a regular basis, and that subsequently try to record all the births and deaths that occur to that population and map the family relations between members of those populations. So we use those data to select 159 families at random, 159 families constituted of 2 or more siblings that were still alive at the time of our study. And what we did is to randomly allocate one member of that family to an in-person interview, so the typical type of mortality data collection. And then we asked them to refer their sibling to us by mobile phone so that we can collect the same data from them over the phone. On one hand, we have somebody who's interviewed the same way as they would be during a DHS, for example. And on the other hand, we have their siblings who will be interviewed by mobile phone. And so in the in-person interview, we included typical questions of the DHS about sibling and parental survival that generate data on adult and old age mortality, and that are used to generate mortality estimates at those ages in many low-income countries. And in the mobile interviews, we included subsets of those questions about, on the one hand, maternal survival, on the other hand, the most recent sibling death that might have occurred in this family. Okay, and so then our attempt was really to try and see the level of concordance between the data that is reported in person versus by mobile phone for the same family members, for the same deaths that occurred within the family. And so here, briefly, what we found is similar levels of data quality and consistency between in-person and mobile interviews. So first thing we checked was how many deaths had missing data on age, for example, and that was comparable in-person and in mobile interviews. And then for surviving relatives. And then we compared the age of surviving relatives reported during in-person interview and the age of the same person reported during mobile interview. And we found a very high level of correlation, 0.78, with very limited evidence of any kind of systematic bias that in-person interviews would yield, that mobile phone interviews, would yield higher age or lower age than the in-person interviews, for example. We looked at the time since the death of various relatives that were reported during the survey. So patterns of missing data seem to indicate that there were fewer missing data. In fact, in the mobile interviews, we have some speculation about why that might be the case. And again, the correlation between reported dates of death was very high in all for all relatives, including mothers, brothers, and sisters, and that persisted if we looked at specific age groups and so on and so forth. Okay. So what we learned from this in general is that the data on mortality collected by mobile phone seems to be in agreement with data typically collected in person. We also learned that it does not take that long to collect, 1 to 2 minutes per relative in that case, to get very basic data on age at death and date of death, for example. However, that trial, of course, it's neat because we can do that within a family and compare to in-person data. But it gives us a peculiar sample of mobile users who were referred to us by a relative. So most likely they had higher level of confidence and trust towards the interviewers that is calling them on the phone. And what we really needed to know at that time was how this would go in a sample of user that we call, so to speak, out of the blue, as is done in mobile phone surveys, where typically we might call a random sample of phone numbers generated within the country. Okay, so next step, we did that. We carried out what we called a non-inferiority trial of mortality data collection with randomly selected mobile phone users. And how did that go? Well, in 3 steps. So first, we recruited a random sample of mobile phone users in Malawi via random digit dialing. So essentially, we dialed phone numbers at random following the country code. And we try to reach a certain number of users in that way. Then among those that we reached, we randomly allocated some of them to an interview about economic activity, so something very accepted in the world of mobile phone surveys. So that was our control group. And the rest of them, we allocated them to a questionnaire about mortality, so recent deaths in their families and households. So that was our treatment group. And then we tried to check whether participation and adverse reactions to the interview were worse in the treatment group than in a control group by setting some sort of acceptable non-inferiority margin at 5 percentage points. So if the treatment group showed outcomes that were more than 5 percentage points worse than the control group, then we would declare the treatment group inferior, and we would not gain much confidence in the feasibility of mortality data collection by mobile phone. Okay. The questionnaire in the control groups, that was a very standard questionnaire used by the World Bank and other groups like Innovations for Poverty Action on employment and household livelihood. In the treatment group, we included questions on recent household deaths of the past 9 months, on parental survival and sibling survival history. For all reported deaths, we got data on time since the death, age at death, and death registration. For half of the treatment group, we also asked questions about symptoms prior to death, place of death, and burial practices. So where the decedent was buried and in which district. And in both groups, we also asked questions on reaction to the interview adapted from questionnaires typically used in post-disaster surveys. So questionnaires, for example, that were administered after 9/11 or after the Haiti earthquake to try and see whether an interview might have generated further stress on the respondents. Okay. We also planned for psychological support if we identified respondents who needed such psychological support. So we had a clinical psychologist on the team who trained study interviewers in recognizing signs of distress and also remained on call for the entire duration of the study in case one of the respondents wanted or required immediate assessment and potential referral. So we had that kind of guarantee or insurance, if you would like. The outcomes were very simple. Primary outcome was the cooperation rate. So the total number of completed interviews divided by completed interviews plus refusal plus callbacks plus discontinuation. So callbacks are people who told us, yes, I want to participate, but can you call me again in 10 minutes or 2 hours? And we never reached them again. And discontinuation are people who hung up on us or instances where the network didn't cooperate. Secondary outcomes were stated intentions to participate in future interviews, the likelihood of discontinuation of the interviews, and the self-reported experience of negative feelings. And I'll jump into the results very rapidly. So in total, we recruited close to 1,700 phone users out of more than 7,000 calls that we and phone numbers that we tried to contact. We allocated them to the treatment group in a 3-to-1 ratio. So we had 75% of our sample was administered the mortality questionnaire. 1/4 was administered the economic activity questionnaire. And that's the headline finding here, is that on none of the outcomes we considered was the mortality questionnaire inferior to the economic activity questionnaire. So we had similar levels of cooperation, similar levels of completion. Negative feelings were not more frequent in the mortality questionnaire, and intentions to participate were just about similar as well. Okay, oops, that's not what I wanted to do. I'll skip that. So in total, we referred 9 of our participants to the clinical psychologist. 6 were in the treatment group, 3 were in the control group, and there were also cases of distress in the control group due to, for example, recent economic hardship, difficulties in accessing water. All of these were causing distress in respondents. That also required attention of the clinical psychologist. We checked by having supervisors follow up on a random sample of respondents to see if maybe we missed some potential referral because of self-reported behaviors, and in general that wasn't the case. We didn't find any additional need for referral after the supervisor interview. It didn't take that much more time to collect data on mortality. So approximately, again, 2 to 4 minutes per relative, depending on the type of question asked. So it seems well within the bounds of feasibility. And interestingly, the last thing I'll mention here is that we also were able to elicit a fairly large number of deaths that weren't previously registered with the civil registration system in Malawi. So it seems like we are filling a gap or complementing existing data collection system. So close to half to 2/3 of the deaths we elicited during these surveys were not previously registered with the civil registration system. So in conclusion, the belief surrounding feasibility of mortality-related mobile phone surveys seem to be largely dispelled in those trials, and mortality questions are not more sensitive than other more widely accepted questions about economic activity. So it seems like this has a lot of potential to keep track of some occurrence of excess mortality if we can work out a number of additional problems with the use of data generated by mobile phone surveys, including in particular whether we have sufficient sample size and statistical power to keep track of mortality. So right now we are trying in a larger scale project various new recruitment strategies that might help us increase sample size at relatively low cost. And we're also working on sample selection biases and correction that might be needed to account for imperfect access to mobile phone in those local populations. So that's work that's ongoing with colleagues in London and at the University of Louvain in Belgium. Okay, and I spoke for a long time already, so I will stop here and save some time for questions. Sorry for being long-winded.
Thank you very much, Stepháne, for the talk. So we do have questions in the chat, and I'll just call on folks, and maybe folks can unmute and ask the question. So I'll just start from the top. The first question is from Josh, and I think Josh also had some other questions down below. Josh, do you want to unmute and ask?
I'll just ask my last question. If we look at the picture where you showed the registered and unregistered deaths, do we get a sense of what multiplier we should apply and how big mortality is?
In our sample?
Yeah.
Not yet.
I understand it's preliminary and you want to adjust for all these biases, but just to get an order of magnitude.
I wouldn't dare an estimate yet, because this is data based on 1,600 respondents, and so it generated a few hundred deaths that we are basing this on. So we are waiting for more data from the surveys that we are doing at the moment to generate estimates more directly. So we'll have estimates for Malawi and Burkina Faso and other countries in the next few months, I think, based on that.
Thank you. I just wanted to ask you a follow-up question, which is slightly related, Stepháne, which is one of the issues with measuring mortality through these kinds of surveys is it's still a rare event, even in a pandemic setting. And so the sample sizes need to be quite large, but also pretty different, probably based on where you're conducting. So what's a good way to sort of think about these sample size calculations and, in the absence of almost no COVID mortality or mortality data in general in these settings?
Yeah. So that's a great question, and that's one where I think, as in many in-person surveys as well, we have big challenges in statistical power and getting sample sizes that are large enough, not only nationally but then subnationally, as many programs and health ministries would want. So we are starting in general from the most recent estimates that was available in the DHS or something like this, and using that as kind of a baseline against which to calculate required sample size and how many respondents we might need in various areas. But what we are especially working on right now are recruitment strategies to try and increase sample size as fast as increase sample size well beyond what we might get in a typical household survey. So how that would work is to move some of the mortality question, try and move some of the mortality question in the form we use to screen respondents. So asking respondents 1 minute or so into the interview whether their parents are alive, and if so, we would oversample them at a high rate. If not, we would undersample them, and so try and see, because in this way we can accumulate fairly large sample sizes much more rapidly than we would otherwise do. So the question here then becomes whether people actually do answer those questions and answer them in the same way, that if it comes after building some sort of relationship with the interviewers and building some confidence, or if this may bias the mortality data we generate in those ways. So we are doing that at the moment in additional trials in Malawi and in Bangladesh. Okay.
Thank you. I think Michelle, you had a few comments. Do you wanna jump in?
Sure. I was curious, Stepháne, about the response rate through interviews through mobile phone, and then you got to the slide where you kind of talked about that a bit when you do callbacks and follow up. And maybe you could just briefly say a bit more about your thoughts on response rates through mobile interviews versus in-person interviews, and how that might possibly bias these mortality estimates.
Yeah. So that's a great question, and one that's also somewhat complicated. So here you see in our study we called more than 7,000 numbers, and we managed to reach approximately 3,000. And out of those 3,700 immediately told us they don't want to talk to us, so they hung up right away. And so that's approximately the type of refusal we might get, because these are the most frequent refusals. When we start talking with people on the phone and they are better disposed towards us, the response rates are actually fairly high. We have some attrition here because we also imposed some quotas on sampling, where we try to get sufficient numbers of people in various regions of the country, sufficient numbers of people in various age groups, so that they might report mortality at older ages, for example, among their parents, and that type of consideration. So in the end, you know, the contact-specific response rate is much lower than in household surveys, but it's also not that low compared to what you might expect based on the recent experience of phone surveys in the US, for example, where response rates are abysmal. This is much higher, yeah, I lost my train of thought a little bit, but part of the difficulty also has to do with the quotas. So finding, you know, 50 to 64-year-old women who have a phone in Malawi is a lot more complicated than finding an 18 to 29-year-old men. So that complicates this a little bit more.
Okay, we're at time, but I'll take one question. I think Anne has her hand raised. Anne, do you wanna ask your question?
Yeah, I just had a comment, which is there's a recent paper published on Tanzania where people who get accidental calls from people they've never heard of, a huge proportion turn those into interactions. That is, they continue the call of wrong numbers and try to create a relationship with the person. So the way people think about being called in a place where any kind of connection to anyone can potentially be valuable is just really different than what we would assume outside of these poor countries, especially in Africa, I think. And then the question really is about whether there are things you could do to increase your response rate. And I assume you have no idea what region of the country you're calling people in with a random survey, but I did a small mobile phone survey and got incredibly high response rates because it was local interviewers and it was some kind of snowball sampling, and basically no one turned, everyone. Mm-hmm. The other question is, do you use any incentives? And I'll just say the two things that worked incredibly well for us was a tiny incentive given over the mobile phone and repeatedly calling the same person, having the same interview, call the same person more than once. And that turned them into a reliable friend. Mm-hmm. And people started telling us much, much more honest and complete things than they did in the first round.
Yeah. I think these are great points, and the building of relation over time. If we were to continue this in a panel survey, I think that would be a great strategy. In fact, we've done this in another study more focused on COVID behaviors and COVID-related behaviors, and it's true that greatly helps. We did give an incentive, approximately $1 in airtime in phone units that people were getting for participating in the survey. Same in the control and treatment group. But those who refused, very often we didn't even have time to mention that there was a potential to get some airtime out of participation. They immediately stated, you know, that they didn't have time, or they hung up. Period. We asked interviewers to record what the potential participants said when hanging up, or when indicating that they didn't want to participate. And so the most common reason was, I don't have time for this. That was so it seems a little bit hard to address that, except maybe calling at different times of the day, or calling on weekends, things of this kind. Otherwise, it's a little bit tricky.
Okay, I apologies to the folks whose questions we didn't get to, we're gonna end so Stepháne can chat with our students. But there's a lot of great comments and conversation in the chat, Stepháne, and we'll happily share that with you, including a comment from Josh who says super important work. So thank you for sharing that with us. We really appreciate it. So let's unmute and thank Stepháne for sharing his work with us.
Well, thank you for the time and questions. I really appreciate it.
Thank you very much. And if you are a grad student or a postdoc, stick